Good evening. This is Dr. Jonathan Dort, and we welcome everyone to the SAGES Resident Webinar Series and tonight's iteration of it. The subject we're going to talk about tonight is the role of endoscopy in minimally invasive surgery for the acute care surgeon. And we have a terrific panel of expert faculty who are going to discuss different aspects of this. We would like to make this an interactive broadcast with discussion from all the participants, so we encourage you to use the chat pod that's located on the left-hand part of the screen, and you can type your questions and comments to the panel, and we'll collect them and turn around and make sure as many of them get answered as we can get. If you lose your audio or your video, exit the webinar, close out your browser, launch your browser, and log back into the show. And if the problem continues, just try restarting the whole computer. At the end of the show, there will be a web link to a SAGES survey, and we encourage you to take the survey in order for us to make our upcoming events even better. The show is being recorded. It'll be available to view online at the SAGES website, www.sages.org, within the next 2 to 3 weeks. And so with that, we're going to get tonight started with Dr. John Paige, Associate Professor of Surgery at University.
Thanks, Jonathan. Welcome, everybody. I got to say happy Mardi Gras to all y'all in all the other parts of the country. I'm going to talk a little bit about hemodynamic and physiologic changes with laparoscopy. My disclosures, you can see there. And the goal of my talk is to promote the safe, effective use of minimally invasive surgery through education and training. And I have 3 basic objectives for you tonight. One is to describe the important physiologic and hemodynamic changes that occur during minimally invasive surgery. Then evaluate how such changes influence the conduct of an MIS procedure. And then finally, I'm going to compare and contrast physiologic changes related to minimally invasive surgery in different types of patient populations. But before we get going, I always like to start things with a little riddle to get people thinking. So I'm showing you a picture. I'm showing you a picture of the Superdome simulation and training there, and the football team. I'm saying, what do all these things have in common? What does football basically and surgery have in common? You guys want to type out some answers? I can look for them. Give you a second. So I think it's all about handling pressure situations. And that's the main key I want you guys to take out of this, is that the pressure from creating the pneumoperitoneum has many, many effects on the hemodynamics and the physiologic response of the body. So let's talk a little bit about MIS physiology. You all know the history of the MIS revolution. Mouet, back in 1985, was the first to do an MIS procedure. And with the revolution, there were a lot of benefits that were discovered. It showed that there was improved cosmesis, less pain, and quicker return to work. That's pretty much what we find generally when we compare MIS procedures to open procedures. But there are challenges that resulted from going to minimally invasive surgery. And one of the big ones was that there are a lot of different skill sets. You go from a 3D to a 2D world, and you lose your tactile sensation. And the physiology is altered as well. And so we, as laparoscopic surgeons, when this revolution started, had to learn about these changes in the physiology. The main important change, as I said, is the pneumoperitoneum. It has both a chemical and a mechanical impact on physiologically. The chemical impact is from the increased amount of CO2 that goes into the abdomen. The mechanical one is the increased pressure that we get from insufflating the abdomen. The big question is, why do we use carbon dioxide? And the main reason is it's an inert gas, it's rapidly absorbed by the body, and it's easily eliminated by the body, and all those things are good. It's also very inexpensive. And as I said, one of the main things is it's not flammable, so it's very useful. We can go into that environment, we can use cautery, and we don't have to worry about explosions or issues like that. Multiple organ systems are affected when we create a pneumoperitoneum and insufflate the carbon dioxide. As you can see, it's all types of changes involving the central nervous system, the pulmonary system, cardiovascular, renal, immune, and it also has impact on acid base in cells as well as oxidative stress, and I'm going to talk a little bit about each of these in the upcoming slides. First, just a quick review of acid base. I'm sure y'all are familiar with this. As you know, the cell produces carbon dioxide as a byproduct. That carbon dioxide combines with water and it goes into the hemoglobin, and then it dissociates into an acid in the base, into bicarb, and that is released out into the blood system, goes to your lungs, and then in the form of CO2, it is removed from the body, expired from the body through your ventilation. When we do laparoscopy, when we create our pneumoperitoneum, we have a 50% increase in this type of delivery to the lungs of carbon dioxide. The central nervous system impacts are is when we increase the intra-abdominal pressure, what happens is we get an increase in the pressure on the inferior vena cava. You have your lumbar spine has increased pressure, and then the plexus drainage is decreased. And as a result, what happens is you have a decrease of cerebral spinal fluid absorption, and you have an increase in intracranial pressure as a result of creating a pneumoperitoneum. And this is aggravated by the higher PaCO2 that we've talked about that's being delivered to your lungs, and so you get cerebral vasodilatation as well. In terms of the pulmonary system, again, the increased pressure and the increased delivery to the lungs, you have higher CO2. The pulmonary mechanics from the increased pressure, you can see on the right side there, you get a decrease in the functional residual capacity, your dead space increases, your peak airway pressure increases, the compliance of the lung decreases, and then your FEV1 and your FVC also decrease, as well as your peak expiratory airflow. So you get both the physiologic increase in CO2, and then you get all these mechanical impacts that are negative on the lung. Cardiovascular system also is impacted by the increase in intra-abdominal pressure. You get decreased, basically you get decreased blood flow to the heart because of the increased pressure on the vena cava. And then you also have decreased flow from the legs because of the increased pressure on the vena cava. And so what happens is you have an increase in your heart rate from the increase in the change from the increased intra-abdominal pressure. And you also have an increase because you have a higher PaCO2 from a physiological aspect. Your mean arterial pressure increases as well from the PaCO2. It is an increased decrease from the intra-abdominal pressure because of the increased pressure on the vena cava. And you can see that you have conflicting responses related to your CVP and your stroke volume based on the increased intra-abdominal pressure and the increased amount of carbon dioxide in the blood system. You also, because of the higher CO2, you get an enhanced vagal reflex from your nervous system, and that leads to the bradycardia we can sometimes see. From a renal standpoint, again, if you look at the physiologic responses, you have increased pressure, and again, it puts pressure onto the renal veins. and as a result, you have decreased urine output, your GFR decreases, the renal blood flow decreases, and then your serum creatinine will increase. Sometimes it does not change, and you have increased release of vasopressin. Immune system, again, you have increased carbon dioxide, and what that does is it decreases your oxygen levels in the blood system and leads to apoptosis. And also, because you have a decrease in the pH due to the increased levels of CO2, you can have drops in the pH that can be pretty profound. You can see that the peritoneum responds, and you both have intra-abdominal or peritoneal responses from the immunologic changes, as well as systemic responses. And they have negative impacts on your PMN function, including increasing the apoptosis, decreases your acute phase response and your C-reactive proteins, and it has negative impact on your macrophages and the TNF-alpha. I talked a little bit about oxidative stress, and you can see that from a systemic oxidative stress standpoint, you can see that in 9 of 11 randomized studies, that laparoscopy has a better response. However, the local oxidative stress is increased in laparoscopy. So from your use of the pneumoperitoneum locally within the abdomen, you have higher oxidative stress, although many studies do show that from a systemic standpoint, open surgery creates more stress, oxidative stress. Let's talk a little bit about what you do when we do our procedures. One is we put patients in either reverse Trendelenburg or Trendelenburg, and those two have an impact. Not only does the insulating the abdomen, but putting our patients in the various positions to help with exposure have important impacts on the physiologic response of the body. And as you can see, when you put someone in reverse Trendelenburg, as you would say for an upper GI procedure, you have a decrease in the cardiac index. You might not have a change in your mean arterial pressure, and there isn't a change in the intracranial pressure, but it does have an impact on heart function. Now, if you look at Trendelenburg, which we'll do, say, if you're doing a lap appy or something like that, you do have an increase in your CVP, and you do get an increase in your intracranial pressure. So it's important to keep these things in mind in order to understand responses. The one thing about going into Trendelenburg, it does negate some of the negative impact that the insufflation has by increasing that CVP and then helping with cardiac output because you're having that increased CVP. I'm going to talk now a little bit about the impact of the physiologic changes. So if you looked at the issues related to the altered physiology, the main issue with the CNS changes is increased intracranial pressure. So one thing you have to be careful with is you have to be very careful with patients with head trauma because they have increased pre-existing intracranial pressures. If you look at the pulmonary changes, the main change is the hypercarbia you get. And so you have to be careful with patients who have decreased pulmonary reserve, i.e. patients who have COPD or in septic shock or have decreased cardiac output. And the other thing is you're going to have an increase in the minute ventilation, so you have to be careful with your PEEP. Cardiovascularly, you can see that we saw that you get increase in heart rate, you can get an increase in the mean arterial pressure, and a decrease in your cardiac output, and that all puts you at risk for myocardial infarction. So you have to be careful when you have patients who have heart disease, and you have to be thoughtful about doing some intraoperative monitoring in those situations. And finally, you're going to have increased venous stasis in the lower extremities, so you have to be mindful that you have your DVT prophylaxis has to be thought about in these cases because of the stasis, because of the increased intra-abdominal pressure leading to decreased blood flow from the lower extremities. And then finally, the issue of decreased urine output from a renal standpoint The main thing is just to understand that and monitor it. I can tell you a lot of times I get the, oh, you know, the urine output hasn't been that great, and when you desufflate the abdomen, it'll pick right back up. And you'll have to be mindful of that, monitor it, and be aware of your fluid balance. Now I want to talk a little bit about some differences that you might see in certain populations. So in the morbidly obese, it's very important to keep in mind that they have an increased intra-abdominal pressure to begin with. And so insufflating is going to exacerbate the effects that we see from an increased intra-abdominal pressure, because they just by being obese with that central adiposity and the adiposity in the abdomen have increased pressure. The other thing is they're at especially high risk for deep vein thrombosis, and so you have to be more aggressive in the type of prophylaxis you're going to do, and based on the case. And the other thing is to be more, have some more extensive monitoring for pulmonary and cardiac issues in these individuals, because they have very low physiologic reserve. If we talk about pregnant women, laparoscopy has been shown to be better than open surgery. There's less fetal depression, and there's less uterine irritability that can, you can see that can sometimes lead to preterm labor. The safest time to do it, as with most operations in pregnant women, is in the second trimester. The hemodynamics are the same as with other patients, and you will see a decrease in the cardiac index, increase in the mean arterial pressure, and increase in the SBR. At 20 weeks, you're going to have an enlarged uterus, and you have to keep in mind that women at this stage are going to have decreased venous return because of the enlarged uterus in the supine position. And you have to be very aware that in the Trendelenburg birth position, this is going to be aggravated. There is some theoretical concerns regarding CO2 absorption within the fetus, and that leading to some decreased uterine blood flow. And miscarriage rates, you can see there that miscarriage rates are lower in the second trimester. What about kids? Well, you have less volume for your gas to insufflate into small abdomens of children, and that's going to increase your intra-abdominal pressure. You want to keep your pressure lower than the 15 millimeters of mercury we typically do for adults, trying to go more like 10 millimeters of mercury, and that'll help with that. The other thing is you want to, kids have more efficient CO2 uptake, and so you might have to look at increasing minute ventilation, and you have to think about cardiac irritability. So in summary, MIS physiologic changes have two main etiologies. One is a chemical response to the hypercapnia that is produced by the use of carbon dioxide. The other is a mechanical response to intra-abdominal pressure by the insufflating. And multiple organ systems are affected by the creation of pneumoperitoneum using the CO2. And awareness of the physiologic impact of pneumoperitoneum on certain types of patient populations will help with proper perioperative management. So again, I wish everybody a happy Mardi Gras.
Who's watching to use the chat room that's on the left side of your screen, and if you have questions that you have for Dr. Paige, and there he is, to write them in, and we'll get them answered. And you can do this throughout the entirety of the presentation.
I must say, one of the, I was talking about dealing with pressure situations from the question, and one of the respondents had an even better one, given the recent events of the Super Bowl. It was about, it's not about deflated. Good response.
Exactly. Well,
so I'm happy to answer any questions.
I'm waiting to see what comes up on the chat screen. We don't have anything yet.
Oh, no. No response means that they were either asleep.
That's right.
Or
You
they didn't
explained it so brilliantly that that's not anything there. Yes, I'll throw one question out because it's one I have, and that's, so given some of those physiologic changes, are there any absolute contraindications remaining to utilizing laparoscopy?
I mean, I would say the one contraindication that's consistent, they're relative. People say people with COPD, it's a relative contraindication. One that I do see that I think is a reasonable one are people with severe coagulopathy. People with severe cirrhosis with severe coagulopathy, gut pressure and stuff like pressure and varicosities and that sort of thing. And that's been the one that's probably the most consistent that I have seen. The others, people have become more relative, but severe coagulopathy that you can't really correct, probably go with an open approach. What about, Jonathan, you agree?
I agree. I think the more that the learning curve goes up, the more people recognize how to focus on those changes and then be aware of them in real time, that what we used to consider, the large list of things we used to consider contraindications have slowly crept away.
Well, the one thing, obesity used to be considered a contraindication, and now it's, it's done all the time.
Yeah, exactly. A certain level of hemodynamic instability, I think, still qualifies. Well, we will. Do you see the question, Sharon? Or
yeah, I see one. Are there any aspects to be considered during a lap BP shunt placement as a combined procedure with neurosurgery? Not quite in terms of the physiologic responses.
Yeah, maybe ICP pressure or ICP.
Yeah, I would just be aware of the, you're putting the shunt to decrease the pressure, and that, positioning would be an important component, and to avoid Trendelenburg. I think if you do, if you put the head up a little bit, that might help. If it's still able to, be able to get the access you need in the abdomen.
All right. Well, I think if we collect questions, we'll break in at the next break. But we will go ahead and move to our next talk, which is Dr. Teresa LaMasters, the Medical Director of Bariatric Surgery.
Yes, I'm here.
Excellent. Okay. And we are going to, Dr. LaMasters is going to discuss the use of MIS in bariatric emergencies. I will turn it over to you.
Great. So my picture up there is because I just returned from Hawaii yesterday. So this is my entry back into the real world here.
Welcome back.
But thank you. I am very passionate about bariatric surgery. This is my specialty, and 99% of my practice is bariatric surgery. So I will tell you, first of all, this topic is way too large to get through in this time frame. So I'm going to try to kind of give you some broad strokes, and then if we run out of time, that's okay. We'll get through what we can here. So my objective is, first of all, to help you just understand the common bariatric procedures and what the common bariatric emergencies would be that you may run into, and then how to use those minimally invasive surgery techniques. So here's a good question for the residents. Why should you care? Why should you pay attention to what I'm saying? So even if you do not perform bariatric surgery, it's highly likely that you're going to see a post-bariatric patient in the span of your career. Bariatric surgery has been done for over 50 years, and now, actually last year the number was 180,000, but for many years it's been over 200,000 procedures performed every year. So it's highly likely that you're going to see one of these patients in your ER someday. These are the primary, most common bariatric procedures performed today. The first picture on the left there is the biliopancreatic diversion with duodenal switch. I'm not even going to talk about that procedure today because it's only done by about 3% of surgeons in the country. So if you do have that case, you're going to want to get a bariatric specialist involved if you can, or definitely take some time to look that up. The Roux-en-Y gastric bypass is still largely considered the gold standard for bariatric procedures. However, it's being surpassed in volume greatly over the past few years by the laparoscopic sleeve gastrectomy, which is over here on the right. We also still have the lap band, which is the lower picture there. And I just want to remind you a little bit about the anatomy of the laparoscopic Roux-en-Y gastric bypass. Just to remind you, you have a small stomach pouch. The bowel is divided and then attached to the stomach pouch and then attached to it back to itself down here. So the food will travel through this alimentary room, which is also called the Roux-en-Y limb. This is the biliopancreatic limb, or the BP limb. So keeping track of where you are is important when you don't do these procedures all the time. So the things that you should think about is people can die with bariatric surgery. It's highly unusual, but it's not impossible. So the risk of death is anywhere from 0.09% up to 1.2%. And it decreases in risk as you travel from a duodenal switch all the way down to a band. Basically, the average for the bypass and the sleeve is really 3 in about 1,000. Half of the deaths are related to pulmonary embolism. Just as Dr. Paige had mentioned, aggressive prevention is very important in this population. The next most common cause of death is actually cardiac related. So the primary risks of the Roux-en-Y gastric bypass are listed here, and I'm not going to go through all these because I really want to focus on a few of them. These are the things that wake us up in the middle of the night. These are the things that are going to end up in your emergency room. A leak, a bowel obstruction, a marginal ulcer, or a stricture. So one of the most important things to be able to recognize is what a leak looks like. Amazingly, the most common symptom is not abdominal pain. The most common symptom is tachycardia, specifically with a heart rate of greater than 120 beats per minute. That will occur in about 90% of patients. It is the most sensitive sign of a leak. The next most sensitive sign is the dyspnea. And this is true dyspnea. They are not just a little winded when they walk. They are very short of air. Respiratory rate greater than 24. SpO2 is usually less than 92%. However, in this population, that could be their baseline. They may present with left shoulder pain, which we call a Kerr sign. Commonly will have a left pleural effusion. They may have abdominal pain, but they may not. They may have a fever, but that's usually a later sign. But if anyone tells you they think that they're going to die or they have a feeling of doom, you need to be very interested and take that very seriously. There are other causes of tachycardia as well. Usually these are not going to reach that threshold limit of that 120 beats a minute. But other things can cause tachycardia, such as inadequate treatment of pain, bleeding, hypovolemia, atelectasis, a pulmonary embolism, or even an MI. Tests to help you determine if there is a leak. An upper GI can be helpful, but it's usually only helpful if the leak happens at the gastrojejunostomy, way up at that top little pouch. Usually if it's lower down and it's the intestinal anastomosis, it's not going to show up. A CT can be helpful because it may show some free air or extravasation of contrast. This can be confusing if it's an early leak, however, because it can still have CO2 present from their original procedure. It is not also completely a sensitive test. If you have a negative upper GI, a negative CT, that does not mean you can feel like there is not a leak. The safest place to determine if there is a leak or not really becomes the operating room. If you think there is a leak, even though you don't have a positive diagnostic test, you are much better to take a patient back to the operating room and prove there isn't a leak than to sit on that patient as they get sicker. So there is an operative intervention and a non-operative intervention for leaks after a gastric bypass. a basic principle is that when these patients have a leak, they really need aggressive fluid resuscitation. You can start that before you really start anything else. If you take a patient in the OR suspecting a leak, I strongly suggest you start laparoscopically. In morbidly obese patients, this really is the technique of choice. You're going to have a much better view of the area of the hiatus and much better access to this area laparoscopically. When you do a big open incision and have a very large liver to deal with in a very dark hole, it can be very difficult to actually access the area of the leak and to try to address that leak. The primary principles are to control the leak. It is not the time to try to redo the anastomosis. If it's a very early leak and the tissue looks good, you could try to oversew it, but usually the sutures will pull through and it will just get worse. Really what you need to do is wide drainage. So you need upper drains, usually by the liver and by the spleen, and then you don't forget your pelvic drain, because if you drain upper, you can think you're doing a good job, and then they'll end up with a pelvic abscess. Another important principle is that if a patient's had a leak, they are going to need to be NPO for a prolonged period of time. The best way to give them nutrition is going to be through the gut. So that means this is the best time to go ahead and place a gastrostomy tube. And you can certainly do this laparoscopically. Again, you're actually helping the patient a lot by placing this at the time of an exploration for a leak. The patient will need IV antibiotics, and you need to also cover for fungal aspects as well. Not everyone will use an NG tube patient on these patients if they're well drained, because it is very uncomfortable and has its own complications as well. As long as they have a diverting gastrostomy tube that can be used for drainage and then later feeding. This is really important for residents to remember, that this sick patient is going to get sicker, and you really need to be prepared for that. Hemodynamic instability is very, very common in these patients. It's a reaction to inflammation. They really do have poor tissue apposition for healing. The real key to this is recognizing it early and intervening early. When several studies were done, they really demonstrated the key differences in how patients do in low-volume, high-volume hospitals really has a difference with recognition and early treatment, or what we call, if the patient had a failure to rescue early, they don't do well, and they tend to have higher mortality. So you want to recognize it early. This is a key principle that works in many areas. In an emergency, make sure to choose the smallest procedure. And I'm just going to give some credit here. A lot of these principles come from the Advanced Bariatric Life Support course that ASNBS gives as well. So the majority of gastric bypass leaks today are actually able to be managed non-operatively. These patients still need aggressive fluid resuscitation. This is a different patient. So this patient needs to be hemodynamically stable. They really have minimal signs. They have a demonstrated contained leak. These are a good patient population to manage with non-operative treatment. This usually involves your interventional radiologist. They will place drains very appropriately, and they can even place a gastrostomy tube as well for drainage and then later feeding. Same principles about IV antibiotics, fungal coverage, and nutrition for these patients. Well, when do leaks happen? Well, gastrojejunostomy leaks after a bypass usually show up early, somewhere between the first 2 to 5 days. And I'll tell you, in bariatrics, we get patients out earlier and earlier these days. So our bypass patients usually leave in 2 days, sometimes in 1 day. So these patients may show up shortly after they've gone home. The intestinal anastomosis, however, can leak later. It can show up even a week to 2 weeks later. And that can be a little bit harder to decipher. The next really important thing that you will be able to see in your emergency room is a bowel obstruction. The overall risk is low, 1 to 3%, but these are patients that you need to take very seriously. So there are several causes for bowel obstructions in post-bariatric patients. The one we usually talk about is something called the internal hernia. This patient will present with epigastric left upper quadrant pain. It tends to be very severe, fairly sudden onset, and radiates to the back. They usually have nausea, vomiting, crampy abdominal pain, they're bloated, and these patients classically have that pain out of proportion to exam findings because the pain is really being caused primarily from an intestinal ischemia, from vascular compromise. I'll frequently get calls from the ER where the provider will say, well, they're really not very tender, so I don't think they have a bowel obstruction. That is not the case, certainly for gastric bypass patients. There are other causes of bowel obstruction as well. These patients can get adhesions, just like any other abdominal surgery patient. They can get port site or incisional hernias, especially if they were an old open bypass. The hernia rate for those patients was anywhere from 60% on up. And don't forget other causes of bowel obstruction. I remember when I was a third-year medical student, I saw a patient in the emergency room that was being worked up for a bowel obstruction after bypass, but they actually had an inguinal hernia that was non-reducible. Now, when we talk about internal hernias, there are three main areas that we discuss. The first area is this transverse mesocolon, and this is a retrocolic pathway for the Roux-Y limb. So that means it goes behind the colon. Many gastric bypasses are done anticolic, which means over the colon, so you wouldn't have this space. The next space is called Peterson space, and it's really the space between the Roux limb and the mesocolon. Now, in an anticolic gastric bypass, there's still a space between the Roux limb mesentery and the colon, and that can still cause hernias, even though it's a bigger space. The third space is the jejunojejunosteny, the mesentery defect of that, and so we call that the JJ defect. The primary principle in bariatric surgery really is to close these spaces at the time of surgery. However, you're really swallowing fat to fat. And as that fat melts away, little spaces become big spaces, suture can pull through. So even if these spaces were all closed with permanent suture, they can still get hernias later. That is no guarantee that they won't have a hernia in the future. This diagnosis is really made clinically. The only really consistent finding for these patients is pain. They are not always going to have a high white blood cell count. Again, providers will call me, well, their white blood cell count's not high. I think they're okay. By the time the white blood cell count elevates, the patient's very, very sick, and the bowel's very far along that ischemic pathway. CT scan is probably the most helpful diagnostic test, but it's still only going to be diagnostic 85% of the time. So again, this is something where if you really think this is what's going on, the best place to make that diagnosis is probably the operating room. Abdominal x-ray can be helpful to start with because if you see an obstruction, you already know where you're going. But if it doesn't show an obstruction, that doesn't mean that it's not there. These patients usually present with severe intermittent epigastric and left upper quadrant pain that happens 6 months or more after a bypass. These patients sometimes have presented to the ER multiple different times at multiple different places with this intermittent abdominal pain, and nobody's been able to figure out what was going on. That is a classic story for an internal hernia. Just like other hernias, it may slide in, it may slide out, but if it gets stuck and strangulated, that's where they can get sick and even die very quickly. Really, the diagnosis is based on that history, and then you can confirm the diagnosis in the operating room. So if you think somebody has a bowel obstruction after a gastric bypass, there are different techniques you can use. I really, again, strongly advise unless the patient's so massively distended that you don't think you have any room at all, to try a laparoscopic evaluation. You want to prepare yourself for success. So that means, first of all, tuck the arms. Make sure you have access to the upper and lower abdomen because you're going to need to run the entire bowel. So you want to prep from nipples to pubis. Make sure they have a footboard and be prepared to open. I strongly, strongly recommend you use an open entry technique, or what's called a Hassan technique, because the bowel is usually dilated because they have a bowel obstruction. You don't want to use a blind entry technique. This is really key. If you learn nothing else that I say today, please learn this. When you get in there, it's going to be very confusing. Find the terminal ileum, just like you're going to do an appendectomy, and then you work your way back proximally. If you start at the ligament of Treitz, sometimes you make the pretzel tighter, and you don't know which way is which, and it doesn't make sense, especially if you don't do this routinely. So start distally, and it's going to unravel the twist as you're running the bowel. Then you have to go back and figure out where the problem was coming from. Was it a jejunostomy defect? What was going on? A big reason I advocate trying the laparoscopic evaluation first is I've certainly found several of these patients who just have a single adhesion band. Sometimes from the jejunostomy to the terminal ileum, you cut that one band and you're done. And you've just saved this patient a big open surgery, a prolonged recovery. These surgeries can be very confusing. Do not feel bad at all to convert to an open technique. If you get in there and it just doesn't make sense, just open the patient and take care of the problem. That's what's most important. I've also been called by providers and said, well, the patient doesn't have an obstruction because they have contrast in their colon. Don't rely on the fact that there's contrast in the colon to determine there's not obstruction. Remember that biliopancreatic limb, that can cause a torsion there and end up with a blind limb. And essentially you get a dilated gastric remnant that can literally blow out. These patients are in a lot of pain. They are very, very uncomfortable. CT scan is very diagnostic for this. When you're looking for a bowel obstruction, and I'm sorry that I don't have a picture today, look at the gastric remnant. The gastric remnant should be decompressed with a very little amount of fluid. If it's very distended and it has a lot of fluid, you should be immediately concerned that there is a bowel obstruction. This is another key point. Please learn this. An NG tube is not helpful, and it is potentially dangerous in these patients. If you have a post-bypass patient that you feel like needs an NG tube, that patient needs to be in the operating room. Another cause frequently for epigastric abdominal pain is a marginal ulcer. It's called a marginal ulcer because it occurs at this margin of the gastric pouch and the jejunum. And it's usually on the jejunal aspect, also an important thing. So if you do an endoscopy and you don't look on that jejunal aspect, you can miss it. These can occur early or late. They present with epigastric pain radiating to the back. The key difference between this and the bowel obstruction is it's usually associated with eating, and they may have nausea, but they don't have the crampy abdominal pain. It's usually a gradual onset, and probably 80% of the time it's going to be associated with either smoking, NSAIDs, or another causative agent like steroids, high amounts of stress, methamphetamine use, cocaine use. These can all be causes. So you talk to them and they said, oh yeah, I started using ibuprofen last month for my plantar fasciitis. Classic story. It can cause pain, bleeding, stricture, perforation. Abdominal x-ray is pretty much only helpful to rule out a perforation or looking for signs of free air. CT scan, really the same thing. You're proving first that there's no obstruction and other causes, but really you can also determine if there's an actual perforation of the marginal ulcer. This can be diagnostic and therapeutic. A GI cocktail with an antacid and viscous lidocaine. If the patient has instant relief, it's very diagnostic for a marginal ulcer. And really your definitive test is going to be your endoscopy. And remember to look on the jejunal aspect. The initial treatment really is medical, and that means high-dose PPI and Carafate or sucralfate. So there's both non-operative and operative management of a marginal ulcer. Primarily, you're going to use a non-operative management in an emergent setting. Only operative time you would do is a perforated ulcer where the patient is very sick. And then you really apply a lot of the peptic ulcer disease principles. Usually do not try to close the hole. It's going to make it worse. You're going to make the hole bigger. Grand patch with the omentum can be helpful if you can get a tongue up there. But really wash out wide drainage, NPO, antibiotics, IV fluid resuscitation, and then consider a gastrostomy tube in that remnant. So I realize I'm running out of time, so I'm going to kind of skip over a few things. Stricture, just so you know, that's a tight spot usually at the gastrojejunostomy. It's actually the most common cause or most common complication after a gastric bypass. It can happen early or late. If it's in the first 3 weeks, usually don't dilate it, let it heal. After 3 weeks, then you consider balloon dilatation. Here's some take-home points from the first part of the talk here. If a patient has new onset of vomiting, 3 to 8 weeks post-op, it's usually going to be a stricture. And you diagnose and treat that with endoscopy and balloon dilatation. Abdominal pain, especially that's intermittent, arising 6 months after a bypass without a clear cause, is usually going to be an internal hernia until proven otherwise. A diagnostic laparoscopy can be very diagnostic. Late onset of vomiting or bloating is suggestive of an obstruction and evaluated with a CT scan. And don't put an NG tube in bypass patients. If they need an NG tube, they need to be in the operating room. I'm just going to make a couple quick points about an adjustable gastric band. There's still a lot of band patients out there where a band is placed around the top of the stomach. There is a fundoplication wrap over the band to keep it in place. The band is hooked to a tubing, which is hooked to a port that looks like a chemo port under the skin. The primary emergency to watch out for bands is an acute slip with ischemia. Essentially, these patients present with pain, nausea, and vomiting. Oftentimes, they ate something they weren't supposed to, and they had multiple episodes of vomiting, and now they have pain. They can present with obstructive symptoms, potentially not even managing their saliva. What a slip is that the stomach prolapses. It gets pulled up through the band and kind of lops over the band, and that pushes the band down. And we call that a slip. As you can imagine, that potentially can cause ischemia and strangulation. The first treatment for an acute band slip is just to access the port with a Huber needle, the specialized beveled needle, and remove the fluid. That alone will cause most slips to resolve. But if the patient has continued pain, especially with an elevated white blood cell count, and signs of an acute abdomen, then you need to explore them. The principles are really that you access the area of the buccal and you unbuckle it, or you cut the band, and that will usually free it up. If I think that a patient has an acute slip and I'm worried about ischemia, I always have endoscopy available, so I can evaluate if there's any full thickness ischemia. Worst case scenario, you could have to do a wedge resection of that stomach if it is ischemic. So to determine if a patient has a slip, really the best diagnostic test is an upper GI. Again, just because of time, I'm just going to go through this really very quickly. Erosions aren't very common with bands, but if you did find an erosion and part of the band it has eroded into the stomach, it can be very hard to remove. The principle is actually to cut the tubing and then make a gastrotomy lateral and actually come in and remove the band from the inside potentially, especially if you can't get it off just from the outside. And then sewing up the gastrotomy up here and then also closing this gastrotomy. So sleeve gastrectomy, I'm going to try to keep this really, really short. I apologize, Dr. Dort. There are a couple things you have to know because this is the most popular procedure performed today. The things that make us concerned is there's a weak area on the sleeve in everybody, and that's right here. It's a watershed area, and in that position, if it's going to leak 99% of the time, it will be right here. The principles really are the same. Again, that's the weak zone. To take care of a leak, it's going to present a lot like a bypass leak. Rarely do they present early. The key with sleeve leaks is the majority present late, 3 to 6 weeks after surgery. So you need to be really aware that that's a very different presentation than a gastric bypass time frame. Treatment really is very similar. You can use non-operative treatment if the patient's very hemodynamically stable. You don't have a gastric remnant to feed them, so you may use a nasojejunal tube like a Corpac tube or TPN. You may use operative management. Again, drain placement is the big key there, aggressive fluid resuscitation. Long-term treatment usually requires evaluation for a distal stenosis because that's actually usually the mechanism of the leak. So, in conclusion, you are very likely to see bariatric complications sometime in your practice. If you can, try to get a bariatric specialist to assist you, even if it's just over the phone. But many times the problem is going to be very high, near the diaphragm and under a large liver. So laparoscopy really is your friend in the morbidly obese population. So I know I apologize, I'm over time. I warned Dr. George that this was too big of a topic, but we gave it our best shot.
No worries. It was the first question that popped up had to do with the role of endoscopic stenting for the management of leaks.
Okay, so this is an area that's growing. It's being used frequently. However, we essentially don't have the best equipment in this country for this treatment. This is an off-label use of stents. They're primarily esophageal stents that are being used for this application. So it can be used. It's usually used to cover the leak and be able to feed the patient. Problem is they're not well tolerated. Patients have a lot of nausea, epigastric pain, vomiting, and the stents tend to migrate. And so we talk a lot about stents. We don't use a lot of stents. A lot of times, if you can get good drainage and make sure there's not a distal stenosis, a lot of these can heal without a stent. But stents can be useful in some cases. I just would say they're not the panacea we had hoped they would be. So let's see, what do we have?
Next question discusses that the findings of internal hernia missed on CT.
So I really wish I would have had time to find you some great classic pictures. This is really a case you need to look at the CT yourself. I will tell you, if I was going to tell you my clinical experience, 90% are missed on a CT read by a radiologist. Despite education, even for the radiologists who work with us all the time. So yes, you can look for a swirl in the mesentery. That is a great sign, but it doesn't always show. That is a classic sign. If you see it, you know you have an internal hernia. You just may not see that, and you still may have an internal hernia. Usually when you're going to see that swirl sign, it's at the jejunum or jejunostomy, but not always. They also, yes, it can have an SMV thrombosis. Essentially, this is looking like mesenteric ischemia patient. So that's certainly possible as well. We have seen some portal vein thromboses in postoperative patients, too, that present with a mesenteric ischemia type of picture, and you can usually see those on CT scan with contrast as well. But really, my take-home point on that is you need to look at the CT yourself. And swirl sign is great. Dilated bowel is possible. Look at the gastric remnant. If the gastric remnant is dilated and there's air in it, there's very likely an obstruction.
Great. See the question on that. It asks about a hypercoagulability workup for bariatric patients?
Sure.
Given
So
the
this
risk
is a great
estimate?
question. This is an area of growing knowledge in bariatrics. So we don't do a hypercoagulable workup prior to surgery because I can tell you that I did, we had like 540 cases last year. That would be a very high cost with a very low yield. What we do is treat them all as potentially high risk. So they all receive Lovenox pre-op and post-op. And if they are in what we call a higher risk group, we actually send them home on extended prophylaxis from anywhere from 2 to 4 weeks. There have been patients who have presented with portal vein thrombosis, like I mentioned before. We have about 2,500 patients, and we've had, I believe, 3 patients with portal vein thrombosis. 2 of them were found to have genetic hypercoagulability after they had their thrombosis and they were tested. Interestingly, one of those patients had a strong family history that hadn't been noted prior to surgery. And so we started really screening patients more with, has anybody in your family had blood clots before? But really the cost to benefit ratio of testing everyone prior to surgery wouldn't really be there.
All right. Well, if I can remind my audience, the participants, to continue to forward your questions to the chat room. We'll make sure everything gets answered before the end. I can remind my speakers all to stay with us because we're going to have a panel discussion at the end of any of these. Who is Associate Professor of Surgery at the University of Minnesota in their General and Bariatric Division, and she's going to discuss the use of minimally invasive surgery in emergency hernia repair. And I have to mention that she has been a trooper because she has done this on short notice, and we very much appreciate her coming.
Thank you, Jonathan. So I'll try to get us hopefully back on time. I'll do my best. So I think that we're going to start with this algorithm and come back to this algorithm in the end, and hopefully these are kind of the 2 slices of bread, and the sandwich in between is all the data that's hopefully going to support this type of an algorithm to take care of patients with non-reducible hernias. So if we just spend a little bit of time here, I think that we first start with the patient who reduces with incarceration, and so then we go on to laparoscopic exploration. And so then you can look and see, is there viable bowel? Is there non-viable bowel? If there's viable bowel, probably go ahead if the laparoscopic repair is what you're most comfortable with synthetic mesh. If there's non-viable bowel, then I think you have to move on to bowel resection and anastomosis. We can talk a little bit more about whether laparoscopic or open, but I think most people would say, hey, you've got to get that specimen out anyways. Why don't you make a small laparotomy and do an open bowel resection? And then this is an area where I think that the needle is really moving a little bit in terms of what to do next once you've done a bowel resection. And there's more and more data which shows the use of synthetic mesh in contaminated fields and that it may be a reasonable option in the right patient. So let's say it does not reduce on induction. You've got incarcerated, you go into the OR. Definitely go with an open exploration. There's absolutely nothing wrong with that. You can go ahead with a laparoscopic exploration. And then in the OR, if you can reduce this, then you can kind of go back over to this side and follow down that pathway. If it's still non-reducible when you have your laparoscope in, then you have a couple of options. Either you can enlarge your defect laparoscopically, or you can decide to go with an open exploration and enlarge your defect in that fashion. And then have a look at the bowel, and again, let's go back down to the pathway that we talked about before in terms of where we move from there. So this is a nice gratuitous picture of an incarcerated inguinal hernia. The issues to really think about are that if you have to consider whether the hernia remains incarcerated at the time of surgery. Does the hernia reduce with induction? Your comfort level with diagnostic laparoscopy, your comfort with laparoscopic hernia repair, the presence of necrotic viscera, and the need for a prosthetic graft. This is a case that we're going to start with of one of my colleagues. So you see this incarcerated hernia here. This is a woman who's 56 years old. who presents with small bowel obstruction. You go to the OR. You find a loop of bowel that's tightly incarcerated in the femoral space, which you're not able to reduce laparoscopically. So on that algorithm, you've got your options. And in this case, it was decided to make a small groin incision. Necrotic bowel was found. The defect was enlarged. The bowel was resected and reanastomosed in an open technique through the defect. Bowel was then reduced. And then the decision was made to use biologic mesh in a laparoscopic tap fashion to cover the entire myopectoneal orifice for show. She did well with no recurrence. That's one way of going about taking care of these complex patients. So what do we have in terms of data? So we definitely have more than what I thought we had out there, which was very little. And so this is a little bit of a summary which looked at 7 articles that talked about laparoscopic treatment, reductions, and repairs of incarcerated or strangulated hernias. And a reasonable amount of cases here with 328 cases with a very low conversion rate, 17 bowel resections. Of course, remember, I mean, this is, we're talking about case series. These are not randomized trials. A very reasonable OR time and an average length of stay, which is also relatively short. They had about a 10% complication rate. Of this, I'm still not quite sure what the most complication of cord induration is, but I suspect it's very minor. This is looking at a retrospective analysis of prospectively collected data of 188 cases over 4 years of strangulated groin hernias where they treated them either laparoscopically or open. And these were patients who underwent emergent surgery for this during the same admission. There were significantly more open repairs, as you can see here, compared with the laparoscopic repairs. Key things to note here are the fact that there was equivalent OR time, lower wound infection rate in the laparoscopic group, and fewer recurrences in the laparoscopic group as well, and as you can see, a lower mean length of stay. Important to remember here is that this is a case series. There's no randomization, so there's definitely selection bias, and it may well be that all the open repairs were more complex cases. So what are the prognostic factors that help potentially guide us in terms of how we should choose the correct patient to approach laparoscopically? Since there still is definitely a debate on how we should surgically manage these patients. This is a retrospective study looking at a large series of cases where a small percentage were emergency surgery for strangulated hernias. Their approach was to do an inguinal incision, and if there was evidence of bowel necrosis or murky fluid, no mesh was used, and they performed a tissue repair. Otherwise, they did a Lichtenstein or a Reeves repair with synthetic mesh, with 1 case of biologic mesh being used. If the hernia reduced spontaneously prior to opening the sac, then laparoscopy via an umbilical incision or through the hernia sac was performed, and then onwards with resection if necessary. With these 49 patients, it was about half men and half women. As you can see here, a higher percentage of women with femoral hernias, which is not new. And there was with the femoral hernias, this is the inguinal hernias in this column, this is the femoral hernias in this column. The largest percentage of both of these types of hernias, there was usage of mesh. In a smaller percentage, there was less use of mesh. And then in the patients that required exploration with the inguinal and femoral hernia, there was about 3/4 in both groups that did not require any exploration due to a reduction of the hernia contents before they could be examined. Finally, this is looking at their outcomes with the patients who required a laparotomy as opposed to those who were looked at with hernioscopy or laparoscopy, and whether they had complications postoperatively. I think the key thing to notice here is that 50% of those who required a laparotomy required an intestinal resection. Therefore, I don't know that it's really a fair comparison to say that the laparoscopy group did not have any complications. It's a different patient population. What about using TEP, or totally extraperitoneal repair, to look at these acutely incarcerated inguinal hernias? So I think the important part of the study is to look at the first author, who's George Fursley, who is kind of the Superman of extraperitoneal repair. He's a true expert who will do TEPs for recurrences after TEPs, where many of us would go for another approach. So as we look through this, we need to try to think of, is this for most of the mere mortals, or just for those who are truly the experts of experts in totally extraperitoneal repair? So he looked at 4 years retrospective study of TEP repairs of acutely incarcerated inguinal hernias, found a small number. Of that, a third of them had an open operation for bowel necrosis, and 11 were attempted laparoscopically, of which 3 were converted to open. The results are interesting. However, I think even more interesting is the descriptions and the pictures that are in this article. So this is looking at a direct incarcerated hernia, which you are unable to reduce, which is gentle traction. And here's an approach to how to make that defect larger to allow reduction. And so if you go laterally, you can see that you'll get into the epigastric vessels. If you go medially here, then that's usually the safer area to just open up that defect a little bit more and to be able to reduce the contents of this hernia. Now, this is an indirect hernia. Here, you really can't go laterally because you have the cord structures, and you'll probably injure them. So you have to go medially, and you are most likely going to be forced to take the epigastric vessels, which is really not a big deal. Now, they did open all of their hernia sacs, and one of them to assess the bowel before they repaired. One of the complications they had was from doing this and getting into a sliding hernia. So another reason why maybe you want to consider a TAP approach if you are going to be doing a laparoscopic exploration for these patients. And then finally, this is looking at a femoral hernia that's incarcerated here. And your approach to open this up a little bit more, if you can't reduce it, is going to be medial, where you have the iliopubic tract and Cooper's ligament coming together, and this is the safest area to open that up. So conclusion, it's feasible. I don't know that I would use the word entirely feasible. Maybe in Dr. Fursley's hand, it's entirely feasible. However, I think this is the key, is that you really have to be quite an expert at the TEP approach and be comfortable with these releasing incisions to approach these incarcerated hernias in this fashion. So what about the TAP approach, so the transabdominal preperitoneal? This is what I think most of us are much more comfortable with. And Bittner's group looked at their cases over a 6-year period, where 24% of them were a group that required emergency surgery, and they approached these with a TAP. Now, this is a little bit confusing because they had 158 that were chronically incarcerated and 36 that were acute incarcerations. I think we're a little bit more interested in these acute incarcerations for our talk today. So when we look at their tables, what we're kind of looking at are these acute incarcerations with a TAP. And you can see they found various different structures that were incarcerated in here. This was looking at open repair. So the C's are the conventional, and this was the open repair with chronically incarcerated, and this was the open repair with acutely incarcerated. With their maneuvers of reduction, they again found that a certain percentage reduced during anesthesia. Again, not surprisingly, the chronically incarcerated, there was only so many that reduced during anesthesia, whereas with the acute incarceration, there were a higher percentage of them which did reduce during anesthesia. And then some required dissection of the hernia sac. Again, not surprisingly, about half of those were the chronically incarcerated ones. In terms of the requirement for resection, they did have a higher resection rates in those that were acutely incarcerated, be it either laparoscopically or with an open approach. And again, this is not a randomized study, so selection bias does suggest that this group, which was approached in an open fashion, may have had more complex hernias or more signs of concern of compromise of the structures that were incarcerated. And then again, looking at their complications, it of course always looks beautiful when you have almost zero complication rate in terms of your TAP repair, but remember again that this is a selected group. So we look at this picture. Clearly there is some questionable bowel here. Should this prevent you from doing a laparoscopic repair? What's the right thing to do when you have some bowel that's either necrotic or is questionable when you first look at it? The data, most of the data that we have is not specifically from the acutely incarcerated hernia group. It's more from the usage of mesh over the last about 5 years or so in infected or contaminated scenarios, and it has been adopted more than it had been, I'd say, about a decade ago. So this is looking at a cohort of 75 patients, and this is in a open repair. And what they looked at was the group that they decided to put mesh into and the group that they did a suture repair. And the important difference here is that just note that bowel resection was done in only about half of the patients in comparison to those that had suture repair. So it is a slightly, it's a little bit of apples to oranges that we're comparing here. Not surprisingly, there was a higher operative time in those that had tension repair. Again, remember that more of them had bowel resection, as well in terms of postoperative stay. Here again, we see how bowel resection was more common. And then same thing, we're looking at bowel resection. And then recurrence rates and were really no different between them. I mentioned a little bit about hernioscopy, which is looking at the contents of the hernia through the hernia sac endoscopically. And this little case series is nice to show some pictures of putting a Hassan trocar through that hernia sac. And this is really for those hernias that reduce spontaneously prior to you being able to assess the contents for viability. And again, looking inside the peritoneal cavity, and obviously if you find some bowel that needs to be resected, that you can go ahead with that appropriately. This is looking at a larger number of patients, so we have quite a few articles that support this. We all know that the pediatric surgeons have been doing this forever, especially in the elective situation, to look at the contralateral side. But we do have some data in the adult patient population as well, including one randomized study. There's a very high success rate in establishing pneumoperitoneum through the deep ring. You can use either 10 or a 5-port, balloon tip, or do purse string around to maintain your pneumoperitoneum. And all these studies concluded that it is a very useful diagnostic tool. I don't think that any talk these days can be complete without talking about some sort of a Swedish registry, since they have amazing data with amazing numbers and long-term follow-up. So this is looking at the Swedish hernia registry and looking at emergent femoral hernias. Again, we can see that quite a large number of women in the femoral hernias as compared to the inguinal hernias when we're talking about emergency repair. And again, this is at an age of 60 and above. This is a little bit hard to look at. I think the important thing that I'd like to point out here is that when we look at the elective repairs for femoral hernias, that the recurrence rate is much lower with the use of preperitoneal mesh as opposed to open mesh or mesh plug. When we look at emergency repairs, which is over here, it's really not statistically significant in terms of the usage of mesh in a preperitoneal or in an open fashion. This, again, just kind of shows us some nice pictures, I think, where you can see an incarcerated femoral hernia here, reduction of it, and you can see the small femoral hernia defect. These were ones that were repaired with mesh plugs. Now we're going to move on to ventral hernias. This is a little Richter's hernia from a port site. These, amazingly enough, I've even seen them with 5-millimeter ports, even though we say that we don't see hernias after those, we do. CT scan showing a small Richter's hernia. These are the ones that are, these small hernias which are incarcerated are the ones that are really fabulous to approach from a laparoscopic fashion, especially in some of the larger people. This is a consensus conference of the European Association of Endoscopic Surgeons. I think the only thing here is that they looked at all of the evidence, and it was kind of grade C recommendation, which said that open is standard, but laparoscopy may be considered in appropriate patients. This was the first little series which looked at Spigelian hernias, which are, again, great ones to approach in this fashion because they're usually small defects. This was back in 2009 where all the world was in black and white. It was very hard to do laparoscopy back then. You see a small defect here and the hernia that's been reduced and some bowel that's a little compromised, and this is a laparoscopically performed bowel resection. There's been a bunch of small series which have looked at these incarcerated hernias, looking at even in large defect size over 9 centimeters, and really trying to stick with what we consider the important parts of ventral hernia repair, which are good mesh overlap if you're going to use mesh, and with some reasonable outcomes in those patients. This is, again, another small series which looked at incarcerated ventral hernias of 25 patients out of their series, and they had a small amount of intraoperative complications, including bowel injury and some venous bleeding from a patient with portal hypertension, and few postoperative complications. This is looking at, again, when we have reduction of these hernias in these patients, where you can always consider laparoscopy to make sure and then decide if you want to place mesh or not. This is a patient who had an obese patient, as you can see, smoker, who had necrosis of his skin from his incarcerated hernia. And this seems like a patient that you're like, oh, I mean, where does laparoscopy fit in here? Well, that's skin. That's not bowel that's sticking out there. So when you go in, you find out that all that is incarcerated is omentum. You can reduce that and put a piece of mesh in laparoscopically. You haven't touched anything out here. You haven't gone through a potentially infected area. And it's a very good option for the rare circumstance such as this patient. Again, this is another one where you look at the skin and it looks a little bit concerning because it's a little bit dusky. But often when you go in and actually look at what's there, it's just the stretch that's made the skin look dusky. If those contents are viable, you can go ahead and do laparoscopic hernia repair. In this not-so-great patient, who's morbidly obese with diabetes, and over time, it's amazing how that skin that you left behind just starts to shrink and can give a pretty reasonable cosmetic outcome. So the caveats to laparoscopy. As has been mentioned before by Dr. LaMasters with these patients who have potential bowel obstruction, open access is probably the right way to go. Varus, you may be very comfortable with it, but when you have dilated viscous, it may be a little bit scary. Bowel distension secondary to obstruction, increased likelihood of serosal tears or injury, so be very gentle with the tissue. And then the risk of adhesions if you've got prior surgery. And remember that you can get visceral injury if you have sliding hernias, such as the bladder. If you need to do a bowel resection, intracorporeal versus mini laparotomy, whatever you're most comfortable with. As I've gotten older and maybe lazier, I'm not sure that I see the clear advantage of doing an intracorporeal bowel resection and anastomosis in these patients. I think the small incision is probably the way to go. Relaxing incision in the fascia, open or laparoscopically, to get everything reduced. Remember, it's better to do that than to yank. And to get some sort of an injury. And occasionally you may need to actually remove that omentectomy to have the omentum to have enough space to do a hernia repair. Primary repair, always an option, especially if you have gross contamination. But there's definitely data that supports the use of lightweight mesh with light contamination. Biologic mesh, you know, it's there. It may get you out of jail if you think that you need it. And then coming back to this algorithm of ours, hopefully it seems like there's a little bit more data that supports it than when we started this talk. Stephen, if you could pull up those videos. So this is a, we'll just go, these are 2 short videos. And so this is looking with a patient who, as you can see, is a little fluffy, who's got an incarcerated hernia there. Came in, had a little bit of skin changes, had a good amount of tenderness, had a white count, if I recall, was about 16, a diabetic with hypertension. But there was nothing systemic that concerned me about this patient, so we decided to go ahead laparoscopically. You can see here that there is omentum that is incarcerated, but we know that there's going to be more, right, because we looked at that CAT scan. And we'll see if this buffers and moves along. If not, we'll just we'll give it another few seconds, and if it doesn't, we'll move on to the next one. Okay, so we're reducing this, and then you can see we still haven't quite gotten to the questionable bowel, and we may not get to it today. Do you want to go on to the next video, Stephen? Well, I guess it's buffering again, so maybe it will show it to us. So there, okay, so that one had viable bowel. Now this one is another video of a patient where this was previously placed mesh, very similar presentation in terms of an incarcerated hernia, again, in a morbidly obese patient. Here you're starting to reduce. You see a little bit of redness, and you go, well, you know, maybe that'll peak up as we move along. But then as you're reducing it more, you can see what is, frankly, a necrotic and on its way to being mummified bowel. And so here you know, this is not somebody that you're going to leave this alone, and you are going to have to do a resection. So this video is going to completely cut off at this point because that decision could be made there. Thank you, and I'll let Dr. Dort decide if we're going to take any questions now or if we're just going to move on and then take some questions at the end.
Thank you for that excellent presentation. We can, if there's 1 or 2 questions board, we can take it. Otherwise, we'll save them for the end. See one coming up. I guess while we're waiting, I know almost on a weekly basis at our M&M, we discuss in the scenario you were talking about the needle moving on when you can use synthetic mesh in the realm of incarcerated hernias that there's a question of viability. Is there enough evidence where if you use it and you have a complication, you can defend it?
So I think this is one of those scenarios where I would definitely recommend to people, don't do it at the start of your career. You're out of your residency or fellowship. This is not the time to say, I've read about this, I've seen my attendings do it, I'm going to put mesh in. I think that once you've established yourself, then yes, you're going to feel more comfortable with these patients. You're going to have a little bit more, I think, I don't want to say clinical judgment, but that's part of it. To figure out who are the right people that are probably going to do pretty well and who are the ones that you just want to get out of jail today. You want to maybe do that suture repair. And actually, that video that we couldn't get to work even showed how you can do your suture repair laparoscopically. You don't even have to open that patient. If the bowel looks okay, but you're still a little bit concerned about them, there's nothing wrong with stopping there. I do think that there is enough data, though, that you could support putting in lightweight mesh when you have minimal contamination in these hernia repairs.
Right. Thank you. Okay, Perfect. Thank you. We're going to finish up with just a discussion of the role of laparoscopy in the treatment of small bowel obstruction. You just saw a great discussion on its use in bowel obstruction related to abdominal wall hernia and inguinal hernia, and Dr. LaMasters discussed its use for internal hernia with bariatric procedures. So I'm going to stick most of this talk to what is the most common source of bowel obstruction, which is adhesive disease. We'll talk a little bit about some of the other causes. So to move along, the goals that hopefully with this segment we're going to discuss the importance of patient selection in achieving the best outcomes. And I think you'll see through some of the data we're going to discuss that really is the key to determining how well things go. We're going to review the available data on the outcome differences between laparoscopy and laparotomy in the treatment of small bowel obstruction. That actually won't take very long. There is a lot of good retrospective data, not really much in the way of prospective data. And then we're going to actually get into describing some specific technical steps that can keep you out of trouble when you do apply laparoscopy in this clinical setting. So, like many things in laparoscopy, it was actually a gynecologist who was the first person to describe this technique. Dr. Dennis Bastug described in 1991 in surgical laparoscopy and endoscopy the use of laparoscopy in a single patient for a single partial small bowel obstruction and for one adhesion that he was able to cut. And suggested that this may be a use that could gain some traction. A lot of the gynecology literature discusses this technique mostly in the evaluation and treatment of chronic pain and infertility. And 1991 in the history of laparoscopy is fairly early. That is just a year or two after Eddie Reddick published his work on laparoscopic cholecystectomy, and within a few years of when the very first cholecystectomy was done. So this was an early adapter for this technology. As you move along, over the next 20 years, not a lot of great data in discussing the role of laparoscopy for bowel obstruction. There are a collection of small retrospective studies, and in fact, when the Cochrane Review was published on this subject in 2010, their conclusion was that they could make no conclusion, because there were no published or unpublished randomized or unrandomized prospective controlled trials, and that there was just a collection of some retrospective trials that did suggest shorter hospital stay and mortality reduction with the laparoscopic approach, but certainly not enough evidence to make a firm recommendation, and they suggested that more studies would be necessary. And so then over the next few years, you do see a few studies that are on a larger scale that try to answer that question, but still of the retrospective variety. This study from surgical endoscopy in January of 2012 from Archana and Winter in Dublin looked at a large collection, a large database of 29 studies, did a systematic literature search, and in those 29 studies, using the phrases laparoscopy and bowel obstruction, they were able to find 2,005 patients that were approached for adhesive disease. Overall, the breakdown of how those patients were treated, 64% of them were completed laparoscopically, 6.7% started laparoscopic and were just then had a small open component, whereas lap-assisted, 0.3% were just converted to a standard hernia repair, and then 29% had to fully be converted for laparotomy. When they looked at the causes for that conversion, the overwhelming most common cause was for dense adhesions. And this is true for many of the studies that you read on this subject, that dense adhesions were primary cause for conversion to laparotomy. The need for bowel resection. Now, depending on where you are in the learning curve, certainly bowel resection and reanastomosis in some settings can be accomplished intracorporally, but this does still tend to lead a lot of people who feel that it's safer to just make a counter incision and externalize the bowel or completely convert to laparotomy. Unidentified pathology. Clearly, if you can't, with a full laparoscopic exam, identify what the problem is, you have to convert for that, and that was one of the more common reasons. And then repair of iatrogenic injury. the thing I think that scares people the most about this approach. They found that when it was a single band that was cut, there was an overall success rate of 73%, and there was that enterotomy rate of 6.6%. Now, most of those were seen and repaired at the time, but I think what scares people the most are the ones that you don't see and cause patients to become very ill. So moving ahead to 2014, in January, in surgical endoscopy, the group at the University of Rochester, Kelly et al., did a NSQIP evaluation over the 5-year time frame between 2005-2010 to try to answer this question. They found 9,619 identified small bowel obstructions, and of those, 14.9% were addressed laparoscopically, and 85% were addressed with an open adhesiolysis. So this is even in the last part of last decade, you can see that although it is an accepted approach, there is still quite a slow adaptation to move this element to a fully standardized laparoscopic approach, certainly much slower than many other diseases that we treat laparoscopically. Their findings, when comparing these two groups, were that patients undergoing laparoscopic procedures had shorter mean operative times and decreased postoperative lengths of stay. They controlled for comorbidities and still were found that laparoscopic adhesiolysis and patients treated that way were less likely to develop major complications and incisional complications, and that the 30-day mortality was 1.3% in the laparoscopic group and 4.7% in the open group, which certainly led them to conclude that the laparoscopic approach seemed to demonstrate a benefit in 30-day morbidity and mortality. If we go later last year to August, we see a very similar study done by Dr. Okranek and his group that was published in August in Surgical Endoscopy. Also was a NSQIP evaluation over the same time frame. 4,600 patients identified with adhesive small bowel disease. Similar breakdown that 19% were addressed laparoscopically, 80% were addressed in an open fashion. And their findings were very similar. They found that the mean operative time was similar in both groups. They found that mortality and overall complications were improved in the laparoscopic group, and you see that the difference is there, 0.8% mortality for the laparoscopic treated group and 2.3% for laparotomy, and the overall complication rate was 8% compared to 22% for full laparotomy, and it was a much improved length of stay. So those two studies agreed. Now, what you could certainly say about those studies is that they're both based on the NSQIP database, which are based on retrospective evaluations, and they certainly have some limitations. This was surgeon preference, and so certainly the patients who were not as sick, the patients who had both anatomic and physiologic elements which would lead to a better outcome could have been taken for the laparoscopic approach, where the sicker, higher risk and more likely to have a poor outcome would have been taken for the open approach, and that definitely plays a bias into how that data has to be interpreted. Also, NSQIP doesn't mention anything about surgeon experience and personal complication rates, and so that there are certainly elements of this that need to be taken with a little grain of salt. However, having said that, those differences were definitely significant to the points that you saw. And there are other retrospective studies that are out there, not as large scale, but all come to those same conclusions, that there are improvements in length of stay, in mortality, in overall complication rates, in wound complications. And what really is needed is a large prospective series in multiple areas that all are in agreement and then could start to standardize this procedure. There was one announced in October 2014 in BMC surgery internationally, where they were asking for participants to enter, and it is going to be a multi-center, prospective, randomized controlled trial, randomizing patients with bowel obstruction to laparoscopy or laparotomy, and their primary endpoint is actually listed as length of stay. Their secondary endpoints return of GI function, commencement of enteral feedings, 30-day mortality, complication rates, postoperative pain, and length of sick leave. There are a lot of retrospective studies that seem to agree that there are improvements in all of these things, but certainly a prospective data would be needed to say that firmly. They list tertiary endpoints of this proposed study that include rates of ventral hernia, recurrence of small bowel obstruction, and long-term follow-ups at 1, 5, and 10 years. So I'm sure that won't be the only prospective study underway. I'm sure there are some underway now, and hopefully we'll have better data from multiple sources that can start to put some of that data into the ability to standardize it better. I want to spend the last few minutes talking about the details of using laparoscopy for these patients, because the improvements that are seen in all those variables in those retrospective studies were because the surgeons made a judgment about a particular patient to do a particular way. And there are certainly guidelines based on that data that we can use to set yourself up for the best chance of success if you're going to tackle one of these situations or any of these situations laparoscopically. Certainly things to consider in patient selection. Patients who are hemodynamically unstable are not the best candidates to do laparoscopically. The speed, it has to be based on the speed with which you can find and deal with pathology, but you also have to consider, in remembering some of the things Dr. Paige taught us earlier, that there are hemodynamic, respiratory, and just overall physiologic consequences of producing a pneumoperitoneum. And if, in an already hemodynamically questionable patient, they may not tolerate that at all. So that is certainly something to consider. And in most cases, hemodynamic instability is still considered a poor choice for a laparoscopic approach at bowel obstruction. Prior procedures. The more likely scenario of success is going to be a patient that has had a small windowed anatomic area, such as an appendectomy or the like, where it's not the entire abdomen that has been dissected and where the focus of the adhesion can be just that, limited to a small area. Your chances of success are going to be higher. Clinical exam. Patients who are tense and severely distended are not going to be good candidates to do laparoscopically. The entrance is going to be difficult and dangerous. The space that you have, the working room that you have, is going to be extremely limited. And so those are not patients that are going to lend themselves well to the laparoscopic approach. The likely pathology. Patients who have not had prior surgery, who may have likely malignancies, while the laparoscopic approach can help you make that diagnosis, depending on your skill level, that may not be something you're going to be able to feel comfortable handling with a laparoscopic approach. That has to be a personalized decision. Pathologies that are linked to the retroperitoneum may be less likely to be handled successfully laparoscopically. And then the experience of the surgeon and surgical team. I put both in there because you can be the grand master of laparoscopy and know everything that you're doing, but if you have to wait 10 minutes for every instrument that you ask for, maybe, and it's 2 o'clock in the morning and it's the ortho team that has come in to help you with your case, that may not be the best time to practice your laparoscopic approach for a patient. So you have to take all of the factors that are available to you when you're making this decision. And so other patients that you may want to consider leaning away from the laparoscopic approach, patients with peritonitis. It's not to say that you can't at least look and get a gauge of the pathology, of what the pathology is, but what the pathology is less likely, depending on your skill and experience level, to be something that you're going to be able to handle fully laparoscopically. Patients with acute perforation, same thing. You may be able to get that diagnosis, and if that helps you to limit an incision, then it's certainly useful in that scenario. But the completion of it depends on your skill level. And then patients just unable to tolerate a pneumoperitoneum. Again, referencing the things Dr. Paige mentioned, if you have patients who are already brittle from a respiratory standpoint, and you now limit the excursion of their diaphragm, or you change their oxygen and CO2 concentrations, that may not be a good idea. Patients who have cardiac issues and may not handle the preload differences, those are all things to consider. Even if technically it's a straightforward thing to do, they may not handle that pneumoperitoneum. So the last thing we'll discuss, and I know we're getting a little short of time, the technical points of once you've found the right patient, made the right what you think is the right selection, how do you approach this? How do you prepare? Quoting Ben Franklin, that if you fail to prepare, you prepare to fail. That is true of these operations as well. So in the preparation stage, make sure your equipment is present, available, and working. You want probably 3 to 5 trocars to handle this operation. Make sure you have angled laparoscopes available to you, because the vision does become poor when bowel is dilated, and adhesions can be stuck in areas that are sometimes difficult to see. Make sure you have what are true atraumatic bowel graspers. Not, if you ask for graspers, you can be surprised by what you might be handed. You don't want anything with teeth or ridges or things that may already damage compromised tissue. Laparoscopic shears that work. You want to have a laparoscopic energy dissector available to you. I say that with great hesitation, because this is a fantastic area to not use energy because of the risks of peripheral damage. And so anything you can do that is sharp or blunt, as Dr. Ramaswamy showed you, is the better way to do it. You want to have an open tray in the room. The risk of conversion is high in these patients, and you want to make sure that when you say, okay, we're opening, everyone doesn't look at each other and then go have to find the open instruments. That has to be in the room. You have to consent the patients appropriately. You can't say, we're going to do a laparoscopic adhesiolysis and assume that 100% of them are going to be finished laparoscopically. Patients have to be mentally prepared for an open incision. When you position patients, you want them supine, both arms tucked. You want to use preoperative antibiotics in case there's a likelihood of an enterotomy or a resection. If the patient is not a gastric bypass patient, a nasogastric tube is helpful in trying to decompress. Use DVT prophylaxis. A Foley catheter is worthwhile not just for decompressing the bladder, but for resuscitation of patients who require that level of monitoring. Make sure your patients are well secured to the bed with appropriate padding, because you are likely to move them around a bit. You're likely to use a Trendelenburg position with the left side down so that you can look at that cecum and that terminal ileum the way Dr. LaMasters described, not just for bariatric evaluations, but for this clinical setting too. We'll discuss about the approach, but you want to be able to get to that decompressed, reliably placed cecum and terminal ileum so that you can march your way backwards and find the right spot. You want to have monitors in your line of vision. You don't want to be torquing your neck. You want to make sure they're ergonomically appropriate. Trocars. I will throw myself on the same bandwagon that everybody else did to please beg you to consider open entry in these patients. I'm an open entry enthusiast in all laparoscopic approaches. I personally think that a Verey's needle is very similar to what our trauma team has to respond to the ER for a level 1 penetrating injury to the abdomen. But that's a whole separate lecture. But certainly in these situations where there's dilated bowel, there is space issues where that dilated bowel is likely to be close to the abdominal wall with very little space in between. The potential for damage is great. Please consider using open entry for these. Make your incisions away from the scars. I think that makes perfect sense, that the adhesions are more likely where the scars have been. Get in far, far away from them. Good triangulation, and use as many 5s as you need. 5s are free. Yes, I agree with you, Dr. Ramaswamy. I've seen a trocar hernia, a port side hernia with a 5mm trocar as well. But if it'll help you maneuver, it'll help you see, if it'll help you dissect, use the 5s as you need to. Start where it's easy. Certainly, I would suggest starting in that Trendelenburg left side down so that you can go to the cecum, you can go to the terminal ileum, and work your way backwards towards the point of obstruction. If you can grab mesentery rather than grabbing bowel, that is advisable to minimize the trauma to the bowel. Minimize the amount of energy that you use, because energy in that setting where there's not a lot of room can quickly disseminate and cause collateral damage. And if you can't see through it, don't cut it. It should be flimsy and see-through if you to cut it. If you are not making progress, change it up. Change the positioning, change your camera angles, try new trocars. Spending an hour looking at the same tissue is not helpful to the patient, to you, and you have to always be making progress. At some point, and I call this the moment of truth, you have to determine that this is not going to be complete. You're not going to be able to complete this with laparoscopy, and you have to be willing to convert it to open. It is never failure to convert to open. It is never the wrong decision to convert to open. You have to do it safe for the patient first, and pride goeth before the fall. So when it's time to convert, it's time to convert. And set a limit for yourself. Say, look at the clock and say, if 10, 15 minutes from now I have not made 1 ounce of progress, it's time to convert it. Reasons for conversion, and I referenced this paper from the American Journal of Surgery in 2004 that I think eloquently laid out what I just said, which is if you're unable to visualize a site of obstruction, you have to convert. Bowel necrosis or perforation is a good reason to convert. Again, this goes back to surgeon skill and comfort level, but I think it is never a wrong decision to convert in that scenario. Same thing for neoplasm or suspicion of neoplasm. It's based on the skill level of the surgeon, the comfort level of proceeding with a much bigger procedure laparoscopically. Iatrogenic perforation, if it's right in front of you and you feel comfortable repairing it laparoscopically, that's fine. Dense and numerous adhesions, again, in a lot of studies is referenced as the #1 cause of the necessity for conversion. And then technical difficulties. If you're spending 10 minutes waiting for a camera to work or waiting for an insufflator to work right, anything that is clearly going to make it a less safe operation, you have to be willing to make that conversion. Things that you see, again, to consider converting, if the bowel diameter is very large, if you have a very distal obstruction where the entirety of the small bowel is dilated and it's difficult to get, it's very distended, difficult to find room, that is a much more likely scenario where you're going to have to convert it to open to do it safely. Matted small bowel or dense adhesions are sometimes difficult without that tactile sense to be able to do laparoscopically. And again, inability to adequately visualize. You can't hope that it's probably okay if you're looking at tissue and saying that it's time to change your angle or to convert to open. So the take-home points for this section, I know I'm a little over, my apologies, that the laparoscopic approach to adhesiolysis is appropriate in selected patients. It has consistently shown benefits over the open approach in retrospective studies, and that includes mortality, overall complication rates, wound complications, length of stay, have uniformly shown benefits. And so if we can get prospective trials done, if we can get non-biased or at least lesser biased studies done because we can randomize and do it prospectively, I think more and more people would be comfortable adapting this more standardly as the approach. And remember that appropriate judgment and safe practice are the keys to optimize your outcomes. Safety first has to be the rules with all of these patients. I will take any questions.
Thank you, Dr. Dort, too. Excellent, and I would just like to second your opinion. Just a second, I'm going to start my webcam here. About if you're not making progress, change positions. I think that's a great recommendation, especially for small bowel obstruction. You can get very focused on one area, and if you simply go to another area and come back, it can be much easier. So I agree 100% with your discussion there.
Well, thank you. I think that's an important part.
I think
again, I would. Whoever's left, if we have folks who are still out there listening, if there's anything you want to ask any of the panel members, we have about 8 minutes left on the webinar, so we're happy to answer any questions that you have.
So for the panel members, I'd be curious to hear how many people, what percentage of your small bowel obstructions do you approach laparoscopically, and what percentage do you think that you're able to actually deal with the entire problem laparoscopically?
I would say that I base it on some of the factors I talked about. If it's proximal, if it's a patient who has intermittently open closed, where I think I have a better chance at adhesion and it's more proximal and it's not a really tense abdomen, I think those are patients, and they don't have peritonitis. They're hemodynamically stable. I'm willing to put a scope in and look at those patients and see if I can accomplish it. I'm also very quick to say this isn't happening and converting. I don't mess around. If you can't even see to put the second trocar in safely, you got to just make the decision to convert at that point. But I've been successful where the previous surgical area has been small and the adhesion is easy to see and it's easy to lyse. I've gotten into other situations where it has been something other than an adhesion, and it at least has led me to be able to minimize the amount of laparotomy incision rather than doing a complete stem to stern. So I don't know if everyone else has had that experience.
I think that with all of the things that we've talked about between hernia, small bowel obstruction, and bariatrics, I find small bowel obstruction is the toughest of those in terms of saying that laparoscopy, at least in my hands, has a huge benefit. But I think what you pointed out at the tail end is really the fact that it often helps you minimize that incision that you're going to have to make, because it really helps guide you in terms of where you need to go. And often I find you still have to open, but maybe it's a smaller incision than what you needed.
If they're a bariatric patient, I will go laparoscopic all the way, and we'll stick to it. Because I mean, if they have a retrocolic hernia or a Peterson defect or something, I think laparoscopic is definitely the benefit in that situation. I mean, it's a different situation. I also agree if you think it's just an adhesion, as Jonathan was saying, if it's a patient who you think is a small adhesion, then yeah, I usually look laparoscopically, and those are the high success rates.
I would say
they've had like 12 operations, and their belly's just a bunch of scars, then I'm less likely to pursue that.
I would say, most of my experience is with bariatrics, coming in with bowel obstruction. And I would say 90% of the time I will start laparoscopically. I probably is adhesive disease. Occasionally there are, but those are more likely, I think, to be successful laparoscopically than just the general adhesive small bowel obstruction. Having said that, I'm very much an advocate of actually just exactly what you guys said. Put a camera in, and you at least know where you're going and can limit the invasiveness.
So Terry, I think there's a question that was typed up. With Roux-en-Y gastric bypass patients with JJ strictures, do you place a G-tube after revising the JJ?
So I am an advocate of gastrostomy tubes with revisions. I think they can protect you in a lot of ways. And even though they are invasive and the patient has them for several weeks, they can really be a helpful tool. So I am pretty aggressive with gastrostomy tube placement for revisions. So I wouldn't say I do it 100%, but I am pretty liberal with a gastrostomy tube. Having said that, if I completely revise the JJ, and I'm confident in how it looks and how the patient is doing. I would say as I've gotten more experience in my career, I haven't placed very many G-tubes in the last few years. So again, as experience, as you said, early in your career, I think you're probably safest to place a gastrostomy tube that can get you out of trouble. But if I've actually resected and redone the anastomosis, it's probably unlikely at this stage of my career that I would place a gastrostomy tube.
All right, so how many people close 5 millimeter ports? I don't.
Nope.
I don't see it.
A picture like that, I think I
to
should.
think about, but I don't close that fascia. I never.
How
I
about,
know we do see it.
do all of you close that 10-12 ports that have been placed with something like an XL trocar?
So
I tend to close 10s and 12s, but in bariatrics, if you do it high abdomen, sometimes I'm not as worried about it. But typically, I tend to close 12 and 10.
I never did. I always kept the 10-12s off the midline, and especially in the bariatric population, and thought I was protected. And then you get one, and then you start doing it. So I converted.
Had that one about years ago and always closed that.
Exactly.
That's the thing is once you get burned, just like with a 5, it can happen with a 5. Of course, it can happen with a 10-12. But actually, Matt Hutter actually presented some interesting work that there were fewer hernias not closing the 10-12. So I think it's just all of what our anecdotal last case was that makes us feel that. But I would say in bariatrics especially, things are moving towards not closing 10-12, especially if it's a dilating, non-bladed trocar. Having said that, if I have a trocar that gets stretched and I can obviously see that that's dilated, I tend to close those still because it's not really a 10-12 anymore. Now it's like a 12-15.
I mean, I think bariatrics, initially at least you've got a huge apron of fat there, and if you're high up there, that's why I think some people don't. In the skinnier population, I mean, I've had Richters from closing. I closed an open, whatever, it was a left lower quadrant port for an appy, and ended up getting a Richter's on it. So I mean, just.
Well, we are at 9 o'clock. We've had a quiet audience today, but unless anyone has any other questions, kind of auction time, going once, going twice. If not, thank you to all of our speakers, Dr. LaMasters, Dr. Paige, Dr. Ramaswamy. I thought it was an excellent session. I thought it was a lot of good pearls and useful information for residents to take back to their call nights tonight. So, thank you all. And
I think the big take home is Hassan.
I'm sorry?
Don't be afraid to do the Hassan technique. Do an open
That's right.
technique.
Be safe. Be safe. All right. Thanks again, everyone. We'll shut everything down.
Audio recording for this meeting has ended.